We will first look at a few cases which illustrate what a typical patient of melioidosis presents with. This patient was admitted under the care of physicians, 49-year-old, known hypertensive. He had pancreatitis related to alcohol abuse. He presented with anorexia, polyuria, polydipsia, and was diagnosed to have diabetes. He had all the features of sepsis. He was picked up to have pneumonia as well as hepatomegaly, and clotting was altered. He was referred to us with history of right knee pain of 2 days duration. On examination, there was no effusion, there was diffuse tenderness, and the movements were painful. Plain radiographs were not very helpful. Ultrasound showed that there was cellulitis with subcutaneous edema, but no abscess collection. Over the next week, it developed into a frank abscess, and he underwent drainage of the superficial abscess around his leg and knee. As he did not respond satisfactorily to the antibiotics, MRI was requested 5 days later, which showed osteomyelitis changes in the proximal tibia and septic arthritis, as we can see in the slides below. He also had myositis changes in the posterior compartment of the thigh. There was some signal change in the femur, but it was thought to be due to edema rather than infection. A few days later, he was taken up for wound debridement when tibial drill holes were made to release the intramedullary pus. He needed another surgery for change of dressing, and during follow-up, these are the serial X-rays. He responded satisfactorily, but more recently is presented with persistent discharge from the tibial incision, and he is awaiting another surgery to implant antibiotic-loaded cement beads. Another case was a 46-year-old Bruneian. He was a known diabetic, presented with fever, weakness, dry cough, and chills. Pus was aspirated from his left leg, and sometime later he had MRI scan, which did show some osteomyelitic changes, but the surgeon under whose care he was admitted opted to drain the abscess only after some time because he was systemically very unwell. Same story, as he did not get better, MRI was done, which this time showed a pathological fracture through the proximal tibia. He underwent another debridement of the left leg and thigh wounds, and subsequent MRI done few months later, as he was not responding satisfactorily, showed that he had an intramedullary sequestrum in the proximal tibia. Further surgery involved a cortical window and antibiotic-loaded cement beads. He underwent removal of beads a few months later, and at follow-up more recently, the pathological fracture has healed. He has a persistent lytic lesion, but unlike the first patient, he doesn't have any active signs of infection. The third case was a young Bruneian who was poorly controlled diabetic. He was already under treatment for melioidosis of the liver and spleen. He was also noted to have pulmonary involvement. His condition worsened. He has to be intubated, and during his admission in the intensive care, he was seen to have bilateral lower limb weakness. A neurological consult was made. Various possibilities were entertained. MRI done to rule out any spinal involvement. On the left side shows that he had multi-level involvement of the vertebral bodies, but no cord compression, hence no surgery was done. It was difficult to obtain any sample to confirm that it was melioidosis, but in the context of his whole picture, treatment of melioidosis was continued, and the subsequent MRI shows healing of the lesions. While we are at the subject of melioidosis and possible tuberculosis, because the imaging studies can be very similar, we also had a case, a lady with neck abscess who was confirmed to be having co-infection by Burkholderia as well as tuberculosis, and certain common factors have to be understood. The risk factors for both these diseases are common. They are intracellular pathogens. In some cases, we see granuloma with central necrosis, much like tuberculosis. It is a chronic disease with relapse, and both infections are resistant to commonly used antibiotics. What is evident from these three cases I have presented is that there are certain common features. All of them are diabetics. They presented with sepsis and pulmonary involvement was very common. Some of them also had splenic and hepatic involvement. In these cases, the musculoskeletal affection has ranged from abscess, septic arthritis, osteomyelitis, as well as myositis. Trying to know more about this condition, which was described more than 100 years ago, and the bacillus is referred to by different names, and the disease is also known as Whitmore disease or glanders. This is an interesting slide which shows the global distribution of melioidosis. And as is evident, most of the cases reported are from Southeast Asia. That's why we should be really concerned about this. And there are increasing number of cases being reported from India, and there are sporadic cases reported from rest of the world. If you look at the environmental suitability, we can see that most of the distribution is around the tropics. And that's not surprising because it is usually spread from contamination of soil or groundwater. It has a broad spectrum of clinical manifestation and can mimic other infectious diseases. That's why it's also called a great mimicker. It can affect almost all the body systems, and as shown at the bottom on the right, musculoskeletal system involvement ranges from 4 to 14%, involving septic arthritis, myositis, and osteomyelitis. Microbiology is very typical. You can grow typical colonies, and for more specific confirmation, the API-20 kit is used. The antibiotic guidelines are now very clear. The initial intensive phase followed by a long eradication phase is essential to prevent relapse. There have been quite a few publications from Brunei about this condition. Some of them have addressed specific organ involvement like pancreas or urogenital, and there was another case report. We got interested in this condition, and one of our first publication was with a very small number of cases, and we have continued our interest in this problem. We also had data for 10 years about antibiotic susceptibility, which confirmed that the susceptibility for meropenem and ceftazidime ranges between 90 to 100%. This graph shows that the sensitivity to ceftriaxone is very low, but it is well known that this is due to the method of testing rather than true low susceptibility. That's why we continue to use ceftriaxone in the eradication phase. By far the most comprehensive publication or data that we have from Brunei, or in fact rest of the countries, was published in this special issue of Tropical Medicine, which looked at global burden and challenges of melioidosis. So we published data from 2015 and 16 in that review article, and since that time we have now about 311 cases. If you look at the demographics, men are more affected. The median age is about 48 years. Our youngest patient was as young as 2 years. If you look at the ethnicity, most of the patients are local Malay, but we have a considerable number of expatriates from different countries who are mostly working in the construction or agro industry in Brunei. This is a very interesting association already reported in some papers. When you look at rainfall and number of cases, the graph at the bottom shows the rainfall in Brunei Darussalam. And in the graph on the top, you can say that the number of cases more or less parallels the number of the months when we have higher rainfall. We also confirm this from data on rainfall in the various districts. For example, the district of Temburong has the highest rainfall, and of the 5 years that data we have, in 3 years, the highest incidence was from the district of Temburong. Moving on to the risk factors, compared to all other countries, I think we have the maximum number of diabetics who went on to get melioidosis infection, and the other risk factors are common like chronic renal failure, lung diseases, alcohol intake, malignancy, In some patients, we cannot find any risk factor. If you look at the presentation, the most common presentation is pneumonia, and about 20% of patients present with septic shock. In our series, musculoskeletal involvement was seen in about 18% of cases. A lot of patients have splenic and liver abscesses, and we had patients who had prostatic abscess, parotid, as well as adrenal abscess, which is very rare. Most patients who come in with sepsis would have their blood culture positive for the organism, and that's how in about 66% of cases, the diagnosis was made on blood culture. More important, I would like to draw your attention to the lower table here, which shows a very high mortality of about 30%. Even with the advances in diagnosis and antibiotic use, this number is quite high. Equally interesting is the relapse rate, which is seen in about 5% of cases. And of those 15, 11 of them had musculoskeletal involvement, suggesting that patients who have musculoskeletal involvement tend to have a chronic duration and more chances of relapse. When we compare our data with data from around ASEAN and more so in Australia, where it's known to be endemic, I think the cases varies depending on the study duration. One thing is certain, that diabetes is the single most important risk factor, and osteoarticular presentation varies from 1.5 to about 18%, as in our series. Another common finding is the high mortality, as one can see in the last column. I would like to share some more cases and lessons we have learned from them. For example, this lady presented with an abscess around the elbow joint, and the question was whether the joint as such was involved. And MRI was quite helpful in ruling out intra-articular involvement, and we could focus on the drainage of the abscess without disturbing the joint. When we are looking at osteomyelitis and septic arthritis, I think we need to have high index of suspicion. For example, someone presenting with septic arthritis may have a very widespread involvement. For example, on the left-hand side, the distal femur is grossly involved, compared to the case on the right-hand side who presented with septic arthritis, but the bony involvement is limited to the femoral condyle. This is very important to plan surgical treatment. And not all patients who have MRI changes have melioidosis infection. For example, this tourist from India who was visiting his relatives had pneumonia confirmed to be due to melioidosis. He complained of groin pain, and MRI showed high signal change in the iliac wing as well as the gluteal muscles. But the same area didn't enhance when contrast was used, suggesting that it was edema rather than active melioidosis infection. We have noticed myositis in most of our MRIs, but we have not really confirmed it by biopsy. But a more recent paper from Sri Lanka has reported on a case where they could obtain biopsy from the involved muscle to confirm it to be melioidosis. So this is another interesting area we want to explore now. In conclusion, it's fair to say that if you have a patient with unexplained sepsis who also has diabetes and pneumonia, there is a good chance that he has melioidosis. And the lessons we have learned from managing musculoskeletal melioidosis is that about 1/3 of patients with sepsis have musculoskeletal involvement. In our series, osteomyelitis is more common than septic arthritis. Patients who have osteomyelitis need multiple surgical procedures. Relapse is more common, and they need much longer treatment than septic arthritis. A lot of patients undergo washout because they are quite sick to have a formal major surgery like arthrotomy. But whenever possible, we feel that arthrotomy offers you better clearance of the infected tissue rather than a washout. We have had few cases who had to be taken back to theater for repeated washout or washout in the beginning, followed by arthrotomy at a later stage. The most important lesson here would be early diagnosis and aggressive treatment. and one should resort to MRI early in the course of the disease to plan the treatment properly. The high mortality continues to be worrying, and it's not only limited to Brunei, it's true for all other countries who deal with this very unique problem. And thank you for your kind attention.